I'm going to do the presentation today, but as we get into the questions and answers, certainly look to Alec and Miguel, or as I go through the presentation, if there are key things that I missed, for them to add to those. I'll just echo what was said. It's just so wonderful to have so many people here and people that have been a part of this process throughout. That will be so wonderful in putting together the recommendations and then carrying that forward through implementation. And I am very pleased to hear those words about the focus on the implementation post-strategy development, because that is absolutely key, and I see all of you as being a part of that. We've had separate groups, the advisory committee and the stakeholders committee, and then we had work groups where selected members of those came together. So I just, by a raise of hands, how many of you are members of the advisory committee? How many are members of the stakeholders committee? How many were on the work group that worked on physician recruitment and retention? Okay. On workforce development, the Committee for Workforce Development. And lastly, the work group on, or committee on community benefit. Okay, great. So we've gone through this process for about a year now. We've had invaluable input from all of you throughout that process, and what we're going to present today are the recommendations that are included in a written draft final report, which is now with the county for their review and editing. And then I'm hoping really to go through the presentation pretty expediently so that we can have a good 40, 45 minutes or even more for discussion at the end. Because again, that's really the valuable part, is to hear from you on things that will be so essential as we move forward from strategy development through implementation.
And if you offered the opportunity for me to speak.
Not yet.
In addition to getting input from you all, of course, we also got wonderful input from consumers and residents throughout the county through community meetings, and it was absolutely vital. Certainly informed by you all, but it was also informed by a much broader group.
Absolutely, yeah. And the community meetings were really wonderful. Just on the objectives for today, I think those are pretty clear, just so that everybody can understand kind of how we bring the project to completion, and then most importantly to provide those highlights from the primary health care strategic plan, and to get your feedback and discussion on those and on moving forward to implementation. So we have a few more things we're going to be doing from December through March. As I mentioned, we have finalized that draft report. It is going through the review and editing process. And then that would be presented, and we would seek approval from the county executive on those recommendations, and then presented to the Board of Health when they convene in, I think those will be in January. And then Miguel will actually do a presentation at the Prince George's County MedChi meeting. And just, not as lengthy as this, but just a brief presentation around some of the key recommendations, focused primarily on physician recruitment. And then finally, we will have a primary care strategic plan presentation at a county-wide meeting that will be hosted by Prince George's County, and that will be in March 2015. I think we're still waiting for sure on the final date, but all of you will certainly be notified of that meeting time. And that would be to present these findings to the community and to get their input as well. So I wanted to start, a lot of you have seen this diagram more than once, I'm sure, but at the very beginning, all of you were very instrumental in helping us to put together the goals for the primary health care strategic plan. And as we've gone through and put together our recommendations, we've always been mindful of working towards these three goals. The first one being access to patient-centered primary care. The second one being improved health outcomes. And then the third one, economic development. And that's the recognition that healthcare was identified as one of 4 industries for Prince George's County to support economic development in the county. So we also wanted to make our recommendations to move to that goal as well. So I want to start off in a little bit and talk a little bit about the assessment of the current conditions and then some opportunities and challenges. If those of you that have gone through the strategic planning process, I'm sure many of you had somewhat of a SWOT analysis, understanding kind of what's our situation, where are there challenges and opportunities for implementing the recommendations. So the assessment of the current conditions really came a lot from prior studies. One of the things that we heard when we started this project is there's been a lot of work that has been done to look at Prince George's County, to look at healthcare in Prince George's County. So please don't reinvent that analysis. And in particular, we use the University of Maryland study, we use the RAND study, and others. And as Alec mentioned, we also did some primary data collection, doing community meetings, soliciting input from you all as stakeholders, doing a lot of follow-up interviews with many of you and other stakeholders to the county so we could dig into issues more deeply. But always kind of coming back to those studies that have been done and understanding contextually what those meant and how that could, how they would inform the strategic plan. So these are not, I don't think, would be a surprise to anyone. Within Prince George's County, we have those higher rates of chronic diseases and poor health status, despite having a relatively affluent population. There are fewer primary care practices and patient-centered medical homes in Prince George's County. And when I say patient medical center homes here, I am referring to those that have been accredited or recognized through one of the accrediting bodies as a patient-centered medical home, so that the public could understand that that they have implemented those initiatives that support patient-centered care. Also, just lack of adequately sized space for medical practices, especially in the low-income areas, so there may not be physical space for physicians to and medical practices to operate. And then a larger percentage of uninsured and low-income uninsured. And this is even post Affordable Care implementation. And a lot of that is driven by the recent immigrants, that there's a receiving center and then a pathway down to live in Prince George's County. And so the county, even after full implementation of the Affordable Care Act, will continue to see a disproportionate share of uninsured within the state. And then finally, another more recent event was Maryland's shift to global payment. And Maryland is an all-payer state, which means that the payers essentially pay providers in the same way. And the global payment was moving away from the traditional fee-for-service to global payment, which we'll talk a little bit more as we go through the presentation in terms of what that means. There's a lot more, obviously, in our report.
For the folks on the phone, make the phone be closer to the veterans a little bit, we'd love to hear.
Oh, sorry. We have some people on the phone. I'll try to project a little bit more. So then the challenges and opportunities. So on our challenges, we have a very socially and economically diverse population within Prince George's County. So with some of the areas that have 25-30% low income to those that have 40-50% higher income populations. We also have some areas that have a mix of Latinos, recent immigrants, African Americans and whites, and then we have others that are predominantly African American. So very diverse communities within Prince George's County, and we really have to build a strategic plan that works for all of those populations culturally, as well as meeting their specific healthcare needs. There's great competition for primary care providers. We're surrounded by the District of Columbia, by Montgomery County, Howard County, Anne Arundel County. So significant competition for primary care providers. And that's been even more so with the Affordable Care Act and more people being insured. The global payment increases that competition. That's one of the challenges, because under global payment, it's very important for hospitals to have strong integrated primary care networks, and so they're all competing for the same primary care providers, and so it just increases the competition. Resources are needed to become a patient-centered medical home. You have to have systems like electronic medical records and care coordinators and the ability to do data analytics so that you can participate in these global payment and quality-based contracts. And that takes resources, and it takes an investment up front. You may get reimbursed for that through higher reimbursement and quality incentive payments that come down the road, but there's an investment that providers need to make to be a patient-centered medical home, and often is outside the reach of smaller providers. And we have to balance collaboration and competition. We realize that healthcare is an industry. Providers do compete against each other for patients, and so we really need to find those places where we can collaborate, but respect also healthy competition. And Prince George's County does not have a specific program to fund reimbursement to primary care providers and other providers for services that are for low-income, uninsured, or underinsured residents. There are programs in Montgomery County and the District of Columbia that are absent in Prince George's County. The opportunities are great in that the strategic plan that you've all helped to develop is very much aligned with what's happening on the state level and the national level in terms of really building on primary care capacity and seeing primary care as an integral part of a continuum of care. When we build primary care practices, it's not only expanding access, but it's also expanding residency training programs. And we heard from some of the physicians that we talked to that oftentimes they end up practicing where they did their residency, and so if there aren't those residency opportunities in Prince George's County for physicians and other healthcare providers, that sometimes can hurt in terms of our physician recruitment and retention. So when we build practices, we also build those abilities for residency programs. There has been an expanded FQHC presence. We had Greater Baden has been here for a very, very long time, and then more recently CCI and Mary Center have also entered into Prince George's County, and federally qualified health centers are very important providers of primary health care and other services, particularly to culturally diverse and low-income populations. Maryland's payment reform does offer an opportunity because it does mean that hospital systems now have an incentive to invest in primary care. Under Pam's guidance, the health department has significantly expanded their capabilities, and in particular around the data analytics, which are so important to helping to understand the health status of the population and how to improve those. And then, as we can see here, we've had tremendous stakeholder collaboration. I've just been incredibly impressed with the commitment of the stakeholders to come and to put things out on the table and to offer to collaborate with one another, not only in the planning process, but going on into implementation. So I want to walk through then the summary of the recommendations that we have in for the primary healthcare strategic plan. The first one that we've mentioned is that we want to increase patient-centered primary care practices and health investment zones. And those health investment zones, that was a term that was created through this process. Those are the ones that the University of Maryland, through their study, indicated that there was a shortage of primary care providers, both medical providers as well as in certain instances dental providers. I'm going to go to the next slide for a moment, and then I'll come back to some of the points in terms of the incentives, but I just want to walk through the medical where the health investment zones are, and the medical practice prototypes that were developed for each one of those. I will just say too that we do have handouts of the presentation, and if we don't have enough for today, we can send them out electronically, so please know that you'll get a copy of the presentation. So when the University of Maryland did their study, and they did a very detailed analysis on what the admissions were to the population, but also looked at where there were higher readmission rates and higher ED utilization that would indicate that we don't have a strong enough primary care base in those areas. And so there were 4 areas that were identified, and in total there was shown a shortage of 61 providers. So we developed medical practice prototypes based upon that study, as well as census data that we looked at for those particular areas, as well as input from the community and from the stakeholders. So the medical practice one is up around the Riverdale, Langley Park area, and that we established really as is most likely to be a federally qualified health center because there is a larger percentage of low-income population there. And it's also diverse in terms of its race and ethnicity mix. That would be also, we looked at that prototype as being part of a larger community center, so that it would be in the same complex as perhaps other social services or health and fitness center. And within this prototype, we actually had a teaching kitchen so that you could use that for your diabetic patients as well as WIC, Women, Infant, and Children program as part of that medical practice. And we also had on-site oral health or dental. And for all of these sites, we have integrated behavioral health services to support the mental health needs of the patient population. Also in that and all the others, we looked at building in exam tables that can go up and down and making sure that we have wheelchair weights so that we can serve persons with physical disabilities and care coordinators that can coordinate the care both for the general population, those with chronic illnesses, as well as persons with disabilities. So prototype one was built on that model, and the business model, the FQHC model, was proposed because FQHCs do get an enhanced Medicaid and Medicare reimbursement because of their federally qualified health center designation. So that would help them to make that more financially sustainable. Medical practice 2 is in the southern part of the county, very different demographically, highly African American, higher income population, but more rural. So some of the shortage might be due to just not having kind of a concentration of population to support a medical practice. So we looked at this as being a shared practice where perhaps individual providers could come together and share reception and other support services and make that financially viable for that particular area. There are medical office space that is being developed in the Brandywine area, and so that could be a location for this medical practice. And we also looked at on-site dental because I think the Angel Clinic that was done there indicated that there was potentially the need for adult dental services in that area. So that prototype was specific to that population, not really seen as a high-growth area. So the practice was developed more with adult rather than young families with children. Medical practice 3 is around the Oxon Hill area. This is an area that is lower income, kind of surrounded by a higher income area. The National Harbor is very close by, so a lot of redevelopment going on there. But it's kind of a pocket of an older population and a higher percentage of low income. And so we looked at that as a family practice. It could be either an FQHC or a private practice, perhaps a nonprofit private practice that could be there. There are office medical buildings in that area where that could support the space that could support a medical practice. This wasn't identified as an area with a dental shortage, and there seemed to be a lot of dental practices in that area, so we didn't put on-site dental or on-site pharmacy because of the size. But with all these practices, you would have integrated behavioral health practitioners. And then finally, on the medical practice 4, that's in the Capitol Heights area. We put that very close to where the Largo Town Center, kind of on the other side, so that it could potentially be part of an integrated delivery system for the regional medical center. Facility-wise, very similar to the medical practice 1, except for this probably would be developed as a standalone facility with a major redevelopment of a shopping center, something like that, where you're really doing economic development for the entire area, and this facility would be part of that, that shopping area complex. And again, tied in transportation-wise to the Largo Town Center. And I just want to say, too, when we were looking at potential sites, we've also evaluated transportation, trying to make these accessible both by public and private transportation wherever that was possible.
Question?
Sure.
So for medical practice number 2, out of the 3, 3 doesn't have pharmacy. You said, I guess they're pharmacies, community pharmacies in the area. But
Right.
2, you said, is a rural area, so I'm wondering, what is the support or number of community pharmacies in that area to support that patient
Right.
group?
So this, I think, because of the medical office buildings that are being developed in the Brandywine area, that you might, working with the developers, and this is part of where the planning department comes in having them have a pharmacy on site. And the same thing with lab. So within the medical office building, you would have a retail pharmacy and probably also a lab that would serve all of the physicians so that each physician didn't have to have their own lab service.
Excuse me, could I respond to that? Hi, Wendy Malloy. We're already established in medical practice under 2, a fully integrated model, and we're getting ready to add pharmacy to that. That's the Brandywine location, which we're also going to expand. So that model is already in place.
Yeah, and thank you, Cynthia. I meant to say that Greater Baden is very close to this site and could potentially build some adult primary care practice, in particular for the low-income population. And it's not to say, I mean, community health centers serve everyone. So I'm not saying that community health centers would only serve the low income, but there are, in looking at the population, the higher income population, sometimes they just feel more comfortable going to a private physician. So I think we're trying to kind of have both of those models there. But building out adult primary care within the Greater Baden site.
Right, but it's good that I understand you want to have that balance, but we have to be very careful because a private practice has the option to pick and choose semi-qualified health center doesn't, so then we end up getting dumped on, and we have to have a very close balance when it comes to our payer mix so we can survive and sustain our business model.
And I think that's, what I'd like to do is, if you have clarifying questions, please ask. I'd like to save the discussion, but I would like to come back to that, because I think that collaboration and the payer mix and the uninsured population are very important to the success of this plan. So thank you for those comments, and I definitely want to come back to that when we have our discussion. Let me just go back for a moment to the incentives around the health investment zones. So again, these are the areas where it's identified by the University of Maryland as having primary care shortages. And so some of the incentives that we provided either directly through the county or in collaboration with stakeholders would be, the first one would be to establish what we're referring to as Prince George's Cares, which is the program for funding for low income and uninsured. And this gets to the point that we really have to be careful to make sure that everybody has a balanced payer mix. And while FQHCs do get some grant dollars, some of them, not all, get grant dollars, it doesn't cover the entire cost of the uninsured. So in order to, and we also didn't, in our planning process, we didn't say that we're going to have like a designated safety net provider network. What we've said is we want all the providers to be part of the safety net. And the way that we'll help that is to have a funding mechanism for any physician, FQHC or private, FQHCs are also private practices, but FQHCs or other physicians, that if they're serving this population and they're a patient-centered medical home qualified provider, and it's a qualified individual, that they would be reimbursed for those services, for the primary care services. There would also be the potential to secure reduced lease payments. This could be through the developers. It's kind of like the trade-off when you do affordable housing. You can have those high luxury condos over here, but we want you to build affordable housing over there. So the county could work with the developers around some potentially reduced lease payments to reduce the operating costs of the practices. Again, this would be for both FQHCs and private physicians. And then really establishing a plan to not to do the loan repayment, but to work with providers and that work for FQHCs and other nonprofit organizations to make them, to help them get access to the loan repayment for both medical and where those loan repayments are in qualifying areas. And those would be in health professional shortage areas. And health professional shortage area designations they could be for medical, dental, or behavioral health, or all three. The same way, kind of in the helping to build the patient-centered medical home, providing low-cost working capital loans, and with some loan forgiveness opportunities, perhaps that physicians that do practice in these areas for the long term. And those loans could potentially be through the Economic Development Corporation here in Prince George's County, or other potential lending sources. And then also establishing a plan to subsidize malpractice costs to the extent that those may be a barrier to establishing a practice. And one of the things I'll just add with the federally qualified health centers is that their providers are most often, not always, but most often covered under federal tort reform. And so one of the other advantages, financial advantages of having the FQHCs is that they don't have to incur that malpractice cost directly for certain providers. So that's the health investment zones. What we also recognized as we got started in looking at Prince George's County and working with you all is that it's also important to develop the capacity for all existing providers as well. So any of the new practices that we would support to develop, we also have to look at existing practices and to help them to operate as patient-centered medical homes. And there are several ways that we put up here to do that. One would be to develop a management service organization or work with hospitals or health plans that might be doing this already to provide those support services to physicians. Because with a patient-centered medical home, again, you have to have systems around EMR, electronic medical records. There's staff training and development around care coordinators. And so there might be other practice management or developing the data analytics to support quality participation in these global payment quality contracts. And that's very expensive for individual providers to do, or small groups. And so the MSO would then provide those services to a broad array of physicians. And it could be on a fee-for-service basis. So the long-term, the goal would be that the MSO is essentially self-sustaining. And then also creating a systematic workforce for patient-centered medical homes. So we mentioned that within a PCMH, your staffing levels per provider may go up a little bit or not change, but you have different needs. And so we need to train a workforce that can do health information data analytics, that can do care coordination, that can support behavioral health integration. So we need to make sure that we have a workforce that supports that model. I mentioned about the clinic training sites. What we heard during our discussions was that there's a lot of competition for clinic training sites, and we need to really give priority to our residents to build our workforce. And then we also heard a lot about quality in terms of one of the reasons why people leave the county is a perception of quality and customer service. So either real or perceived, it does affect their decision in terms of where they get care. So there really needs to be a tremendous focus on building customer service as part of the PCMH across all staff, medical and support staff. This is just kind of a schematic just showing about a patient-centered medical home. This stands for health investment zones, but it's for those as well as existing practices. And then we also mentioned that we want to make sure that we build facilities or have medical facilities that are pleasing and aesthetically pleasing to the population. And then internally, so within our report, our consultant architect had diagrams and photographs of various parts of patient-centered medical homes that they helped to design, making sure that you have enough exam rooms so that you can have as much time with the provider as possible, making sure there aren't physical barriers between the patient and the support staff, and then doing things like having instead of having individual physicians' offices and nurses' stations, having areas where medical teams can come together or health teams can come together and work together to care for the patient. So you're developing that team-based approach to care. And then just other meeting rooms, talking rooms with behavioral health integration. So if a patient needs to see a behavioral health provider, that there can be a soft handoff between the primary care provider to the mental health provider, and they can have space to talk. So the design is different than what you might see in a traditional physician practice, and it again accommodates the patient-centered medical home model. Our third recommendation has to do around building collaboration among Prince George's County hospitals. Again, this is this balancing the competition and collaboration. But we did identify a few places to collaborate. One is looking at the services that are provided within the county, making sure that we balance our centers of excellence around OB, around cardiology, around pediatrics, so that we offer those services within the county, and not to take away from healthy competition, but also not to have too much competition, so that all of the hospitals can be financially successful and can offer the services that residents want and need. The transitional care with hospitals and primary care providers, that has to do with reducing ER admissions and making sure that there's good connection between the hospitals and primary care providers. The Maryland Hospital Association is doing some initiatives around that now, and it might be worth looking at that opportunity in Prince George's County. And then we talked quite extensively about one of the places where hospitals could really collaborate pretty easily is around their community health and needs assessment and community health improvement programs that are required under the Affordable Care Act for nonprofit status, and just offer tremendous opportunity for hospitals to come together to help improve the health of the citizens of Prince George's County. And then the residency programs as well. And this ties into the Regional Medical Center in terms of being academic affiliation to increase the residency opportunities. I've talked a lot about workforce, so I won't go into this too much, but basically, again, it's just developing a workforce that supports the patient-centered medical home model. And that does mean retraining and developing training programs to support that, and having a priority on customer service. The other thing that we had as our recommendations as part of our scope of work was developing a marketing and branding campaign, and it's really focused on this recruitment of physician physician recruitment and retention, and also keeping residents in the county for their care. And we want to, we had two, sorry. So we'll talk a little bit more about that in a moment. I have a couple more slides on the marketing and branding, so I won't spend much time there. The sixth, and this has to do with the sustainability, is to develop an independent primary health care authority that would be stakeholder-led. And one of the first charges would be really leading the implementation of the primary health care strategic plan. It would be governed by an independent board of directors. And its mission would really be to improving the healthcare and the health delivery and the healthcare of Prince George's County residents long term. And some of the roles and responsibilities of the authority are listed here. This is just the potential roles and responsibilities. You could have others. You could decide that there might be other entities that are better to do this, but they could do the MSO, they could do the community benefit, and then overseeing the monitoring and evaluation of the strategic plan. And then that's our final recommendation, and we've heard this loud and clear too, that we need to make sure that not only is the plan, we need to evaluate if the plan is being implemented as it was presented, but also that it needs to ongoing, and that in transparency, we need to put that onto a scorecard or some kind of other reporting tool, and we need to put that out to the public so that they can see that we are achieving the goals of the plan. I won't spend time with this either, but just again, this is a social ecological model that we really use as a context for all of our planning, and it's just really saying that a lot of healthcare takes place outside of healthcare facilities, and so we really need to look at the individual level, the interpersonal level, what's the support system that people have, what are those social determinants of health that we need to address, organizationally, having the patient-centered medical homes on a community level, making sure that we have also places to walk and healthy places to eat and exercise, and then a lot of what we're doing now, the policies and systems that we have to have in place, like a program to fund the uninsured, so that we can make sure that on a system basis that the plan achieves its objectives. So I'm spending a couple minutes on the marketing and strategy goals. Again, those are focused primarily on recruitment and retention of providers and keeping individuals in the county for their care. And it's really developing then a campaign, a marketing campaign with those messages, but also understanding that we have to have these structural changes. So to the extent that we do need to improve our quality, our customer service, we have to expand access, that those things have to happen first, and then we have to promote those things happening. And our brand strategy, so everything that we do, Prince George's County, Our Health Matters, all the initiatives around the primary healthcare strategic plan would carry that brand. And it would first kind of be almost like a public relations campaign to tell the community resident, the county residents, that this is important to Prince George's County and we are making these structural changes, and that we are going to have healthcare providers that are high quality and can serve your healthcare needs, and that you are their first priority. And then this is just some different ways to kind of send that message out to the community, so that, and this is across all primary care providers, so it's not just promoting the health investment zones, it's across all health care providers in Prince George's County to promote the primary health care strategic plan and the advances that we're making. We can't do everything at once, and so basically what is shown here, all the recommendations put in what would happen initially and over the first 3 years. So making those investments in the health investment zones, developing the primary care authority, those would happen in the first 3 years. And then the short to medium term, the 3 to 5 years, we would continue with that last health investment zone placement there near the Largo Town Center. We would be expanding our residency programs because those are essential to recruitment and retention, and expanding the primary care networks of all of the physicians. And then the long term is the Largo Town Center, the Regional Medical Center, having that as part of our healthcare delivery system in Prince George's County, an integral part. And then really recruiting, retaining primary care physicians in kind of this broader package deal. So what we've heard too is that we have to make Prince George's County to promote that it's a great place to live, that has a low cost of living. Maybe we need to think about the school systems, working with improvement of the school systems, and really recruiting that as for physicians and other providers to come and live and work in Prince George's County. So with that, I will stop. And I'm sorry, I didn't mean to rush so much to the end, but I do want to make sure that we have plenty of time for discussion. So, Cynthia, I will come back to you just to ask if there's something else that you want to add from your from the point in terms of the expanding the provider base in the Brandywine area.
Right, I was just commenting to the other lady that asked a question about Brandywine. We're currently located there in that zip code, and we are expanding in that particular facility that we're in now. So right now we have 2 stories. We have a 3-story facility that we provide care in 2 of the stories. The 3rd story is admin. We are moving admin out of the Brandywine location. So all 3 floors will provide primary care. We have an integrated behavioral health model. We do case management. We have pharmacy and dental, pediatrics, and WIC in that location. And lab, and we have one-site lab. And we're taking that model and we're going to be cascading that same concept to our Capitol Heights location. We're going to be moving out of that shopping center, and we're looking for property to build a 5-story facility with a fully integrated model. Both of our centers will be PCMH. We're now PCMH NC2A level 3. And of course, in a same scenario will be for Oxon Hill. So 3 of the areas that you're talking about, we already have expansion plans in place because we've seen the need, and some of the carriers have come to us about expanding our services to help meet the needs of their patient population.
Okay, so you would basically be filling some of those gaps.
Right, that's already in our strategic plan to do that as well. So. And my other thing I was commenting about is just being mindful about payer mix. While we are a federally qualified health center, we have to be very mindful. There is plenty of work to be done. We partner with everyone that's out there to provide care, but we also have to be very mindful that because we are mission-driven, we have to adhere to certain requirements by the federal government, and we have to take everyone regardless of the ability to pay. That makes us different, and we look different when we're partnering with private practice or the hospital because they have options. they can close their panels. They don't have to take certain coverages. We don't have those options to us. So we have to balance how to be able to service and meet the needs of everyone. So we become very creative and think of concepts and options so that we can provide the care to the community. Because we think of whatever a patient needs, we try to figure out how we can do it and create our concepts in-house.
How we move this forward. Is that essentially what? So is there so my question is, given that being the case, do we have an idea of what kind of, there's need to be a budget of some sort, and where it sits? Is it going to sit within in the health department, the county administration?
So the way that we've recommended it, so that's what I'll just say in terms of the recommendation, is that it would be a stakeholder-led, so a board of directors, that would be an independent board of directors, that would be, as any board of directors would be elected and have their bylaws and things for moving forward. So the idea was that for it to be independent. That doesn't mean that it wouldn't have some, kind of maybe sit within county offices in terms of support, in terms of just space and things like that, and also some leadership from the county or some support from the county. We made this recommendation based upon other models that have existed. So close to home, the Primary Care Coalition in Montgomery County is one example of that. Another that we put into the report was Quality Counts in Maine, the state of Maine. Again, is an independent-led entity. They're not behemoth organizations. They're really kept very lean, and yes, they do have a budget, and oftentimes it's the stakeholders coming together to help fund that. You can also get grants from CMS and others to help fund that as well. So it's usually kind of putting together a fabric of different funding streams. The MSO, again, there could be some startup dollars to do that. And with the MSO, I would talk very much with the hospitals and the health plans, because they might be wanting to do that same kind of thing for their physicians in their network, that they need to have them to be able to be patients in local homes and participate in these global payments. So they would, again, from a business perspective, there may be an economic model that helps to share those resources. So it's kind of a shared. I don't know, Betty, if you wanted to say any more to that.
The redevelopment authority, for example, is dotted line connected to the Department of Housing and Community Development. And I think lean and mean would be the way to go,
Right.
especially
Right.
initially.
Right.
Lean and efficient.
Yeah, and to leverage. So when you think about the monitoring evaluation metrics, like the scorecards, we have an example of a scorecard design in Colorado. We put that into the report. You're also going to be collecting metrics for the community part benefits. So you don't need to duplicate that. And so you would really look at what are all the metrics that we want to have, where are they currently being collected. I think the idea would be getting it down to the more micro level, the zip code level or the community level, so that you could continue to make those improvements right at the community level. But definitely leverage all of the existing things that are already being done. And that's why, again, we'll say that collaboration, I don't mean to kind of beat the drum too much, but that collaboration and coming together and really leveraging what all the others are doing is so very important to making this happen.
Thanks. I just wanted to mention, again, I'm Melanie Griffith. I was looking at Councilwoman Turner and waiting for the county executive and looking at Dr. Wright. Almost exactly 4 years ago, when the county executive had his healthcare transition team and then followed up, we had a conference in Prince George's County that dealt with integrated healthcare delivery system for this county. And so I wanted to first applaud the people in this room for tremendous progress that has been made in a relatively short period of time. Change takes a long time in any industries, and healthcare is probably one of the most complex industries in the world. So the fact that we've gotten from a very simple conversation on a complex issue to a plan that looks like this, I think, is to be applauded. I wanted to follow up on Valencia's point about the payer mix, and it may be a conversation that happens when the authority is developed, but I get excited around the conversations about Prince George's CARES, and there may be more information in the packet. but I wonder if at some point we might have a conversation about putting qualifiers into those participating in those funds to maybe suggest that they be responsible for sharing in a certain percentage of patients who are uninsured, so that it doesn't become one entity sort of cherry picking the insured and employed population, leaving another to take care of those without any reimbursement. Because even if there is a fund, it's not going to take care of the total cost. And so I hope that as those conversations develop, Ms. Creek, we're probably on your watch, that we consider that and put some parameters in place so that we're all sharing the burden and collaborating, to take your word, as we move forward. Thanks.
Right, and I would, could I just, on that, the Prince George's Cares, we're kind of looking at Montgomery Cares as a model, that it's this entity coming together, and it's really, you're defining, okay, what are the benefits that we can pay for? Who are the participating providers? How do we qualify them? I think what you're saying.
Yes.
And then who can participate? I mean, the number one thing would be getting anybody who's eligible for Medicaid or subsidized insurance, first priority, that's where you go. Those dollars are available. So it's only those like the undocumented that were not included in the expanded insurance. But so then how do we make sure their eligibility, and how do we make sure we have quality providers? Those are all things that, under the direction of the primary healthcare authority, that those decisions would be made as a county. And some of it will be affordable. What benefits can you really afford? And I think it is multiple collaborators coming together to help to fund that, because that will be, those are dollars, for real, for dollars, yeah. And I don't mean to make light of that. It's not like it just happens magically. And it would take a commitment of providers. But when you think about saving, readmissions and emergency rooms and having chronic conditions go to acute situations, then that's where that global payment also becomes an opportunity.
As Dr. Griffith said, I want to congratulate Betty and Vanessa. This is an excellent product, an excellent report. I'm even more excited than I was 4 years ago about what the county's going forward. My, question, comment, the first one where you say establish a task force on care coordination, that's fantastic. We've been talking about that. If we could get that task force on the coordination, that would be excellent. And I guess that would be you put in some legislation and then we have the task force. I think that's great. On one of the pages you mentioned about, for part of the incentives, you mentioned small loans and things along those lines. My question, and I guess I'm glad we have David Iannucci in the room, could that be, since we're talking about economic development, could that be done in coordination with EDI funds?
It's understood that that's a possibility. We've had, Ms. Francis has been a very strong advocate. We've actually already done that one time. There'll be a ribbon cutting this Friday at a clinic where we use the EDI fund, and the council approved it in a way we had never done before to match a health department grant. So we actually use the EDI fund to match a health department grant to open a facility in the health zone, right?
Yes, absolutely. A health enterprise.
Yes, thank you.
Yeah, sorry, I know.
No, this one will open, this is Joseph Family Medical, and they will be opening in Coral Hills across the street from the CDC. So it was an excellent collaboration on how we could blend all of those pots of money and make it work. Excellent.
Can I just follow up one thing real quick? And I forgot to mention Dr. Charlene Dukes in that integration session and our work to talk about making sure that we had a skilled workforce, not just to feed the new hospital, but also the primary care facilities, because we have workers at all levels of healthcare.
Right.
So the community college is really the first entry point.
And I think there are some programs that have been developed at the community college exactly to that line, because these are new, and it's exciting because it's also a career path for the people that are trained, and it's not just lower level service jobs. So
I think that we'll expand the workforce piece in the final report a little bit more, and we'll include some references to the pilot program with the University of Maryland for interdisciplinary. You say it? interdisciplinary team-based care. That's the one, right?
So, yeah, and there were very more detailed recommendations that came out of the work group committee that are in the final report. And they kind of got a little short-shifted in the presentation, but some very specific recommendations. I think Paul had just...
I did want to comment, I do think that all the ingredients that are necessary to support the recommendations that you're making, they're all available in the county now, and some of them are excellent. It's just a matter of going back to your point of the need for collaboration. The collaboration has to be at the forefront of this. So the question with regard to the authority and then the board, are you going to be making recommendations as to who's going to constitute that board or what you should be looking for in the board? I mean, Alicia and I had a lot of good experience in the DC Primary Care Association when we were both there, and that worked. And there was a lot of great things that were accomplished as a result of that. So I mean, again, we don't need to reinvent the wheel. There's a lot of good models out there to choose from. But I was just wondering, like, how will that be driven?
So JSI will not make a recommendation about who specifically should be on that board, but in our final report, we did give 2 examples of best practices, and in there it talks about the board composition, the roles and responsibilities, and I think also kind of how the board was established, although it's not, we can see about maybe putting some of that in or doing that as a side.
Because it probably goes without saying, but if you want to get the collaboration, then all the different players need to be represented. I understand, but sometimes I think we can get shifted one way or the other, and that balance that we had worked.
Right.
So,
okay.
Thank you.
Okay. Dennis, are you keeping track?
No, I think Pam wanted to answer that question.
We have the opportunity to make something that's absolutely perfect for our county. We looked at a lot of models, lots of models, and JSI did even outside of the area. But each one of the local ones that I've talked with early on, there were opportunities and things that they would do differently if they had to do it all over again. So I think for us, we're going to benefit from everyone else's experience and the things that they would do differently and come up with something magnificent, because it is working in some of the areas around us, but each organization had something that they would change. And so I'm really excited about the opportunity of learning from everyone else's mistakes, so to speak, to have a quick success here.
Yeah.
Lean and efficient.
Right. And you would have, like any board, you would have, you have the executive board, you have the committees, so there would be multiple ways to make sure that you get the interjection of the different constituents. Dr. Wright.
Again, I just wanted to echo the comments of Delegate Griffith with regard to how all the dots have been connected from December 2009, when the county executive first rolled out this conversation till today. It's very nice to see this all come together. The devil is in the details with regard to workforce development. I concur with Ms. Francis's comment there, but while we have our FQHC college in the room, as well as our Dimension College in the room, I thought it would be remiss if I didn't mention the opportunity to align workforce with education. Clearly, with the residency program in family medicine coming online, as Dimensions, and the opportunities that the FQHC community has to subsidize, to apply for grants to subsidize medical education, I think this is an opportunity that we need to have in our mix of tools to both, one, bring resources into the county to support workforce development, and 2, to actually support the influx of bodies, of trainees. I'm not being impolite by saying this, but inexpensive labor. When we have residents and trainees who are able to participate in the county and provide services on the support of federal dollars that our FQHC colleagues are able to leverage. So I just want to make sure that that opportunity is in the mix as we begin to talk about workforce.
And that residency, but we wanted to make sure that it's medical and dental residency, because it's expanding that dental capacity too is very important, so yeah.
Hi, I'm Kim Corbin. I just wanted to ask about transportation concerns. I know for the Brandywine area, the rural areas, or any consideration given for funds available for doctors that make home visits, because we have down in Charles County and even Brandywine, doctors that do home visits, but they're not reimbursed necessarily what they're doing. So if any consideration has been taken to transportation, getting them to the clinics, or either paying doctors that would be willing to go see the patients at home.
That's a good point. I have to say that when we looked at transportation, we looked at, was it in a location that was accessible by public transportation, either current or future, or highway, like, easy access by road. We didn't look specifically at transportation dollars to pay for, as you're saying. So that's an interesting point. I guess we could look at maybe if there's any changes in reimbursement policy, or maybe the global payment situation could also allow for flexibility of dollars. One of the constituents that we didn't, we kind of talked about this a few times, the home health care part of the industry doesn't seem to be kind of a part of the conversation. So would that also be part of kind of bringing them into that conversation as well?
I'm a home health nurse.
You're a home health
that's why I
nurse,
asked,
okay.
That's a big issue when we're going to see patients. They can't get to the doctor for their follow-ups, especially with the chronic care patients, your CHF, COPD patients. Families are not around. They can't make their appointments, so they don't go to the doctor. They call 911.
So I can say that, generally, part of the patient-centered medical home concept would be to understand what are those barriers to getting, because you're asking those questions of the patient when you're doing the intake, not just name and address. So I think identifying those first and foremost, and then looking at either reimbursement policies that might be changed, or again, when the global payment, if dollars can be some dollars can be attributed to transportation. So we'll definitely, I don't have an answer for you, but we can put that in.
Or either, because there are physicians that will go to patients' homes, but their reimbursement from insurances are, private insurances don't reimburse.
So reimbursement for home.
Yeah.
Okay, I had a question in the back. I have a question right here.
Yes, I'm sorry. I wanted to say, consistent with what former Councilwoman Turner was saying, the county has been supportive through the EF fund in providing assistance to us. Still I Rise in opening a women's wellness center, which had its ribbon cutting and dedication on Saturday. We are now able to provide medical screening services to victims and survivors of domestic violence in the 20735 area code, which is in South County, and we're working with Olympia and trying to get some of the referrals as far as screening is concerned. We do have 2 docs on staff and 3 nurse practitioners, psychiatric, OB, and family medicine that we practice. So I think that we're positioned to really make an impact in that part of the county.
What was the name of your organization again?
Still I Rise, but it's called, the actual center is called the Women's Wellness Center.
Women's Wellness.
And it's in Clinton.
Good morning. I was happy to see the collaboration with the national programs, and so I just kind of wanted to ask. I hear resources, financial resources being a challenge, and I'm sure many of you know that Centers for Innovation has recently released $840 million across the country for the Transforming Clinical Practice Initiative. And so my question is really to the group at large in terms of we know that whole initiative is focused on trying to empower and build capacity for primary care practices. Primarily, there's also a piece for specialty practices to become all of the things that we know healthcare reform is directing us to. And so I'm just kind of asking to our healthcare systems that we have in the room, and certainly the FQHCs, is there a conversation, is that an opportunity for us to come together and submit a proposal? The proposals are now due. It was in January. Now it has been moved back to February. Just got that news. And so that's a huge, it's $840 million. They're going to be giving 35 grants away. And it's 2 sides. One is to healthcare systems. It's a grant. So that's about $640 million on that side. And then there's something else called the Support and Alignment Networks. It's called the SANS. And that is towards more of the healthcare associations, family practice associations, the nurses, pharmacies, what have you, to disseminate information to the clinicians in their, in their communities. And so I always keep my eye on, those federal dollars. And so I just would be very interested to open up the dialogue. And my other question kind of is, with the board, with this advisory entity, would they be responsible for possibly identifying funds such as this that could, so my first real question though is to my colleagues that have the practices, are we collaborating? Is there some collaborations? I know nationally, this came from a large national meeting last week at CMS, and they're going after these dollars. So can we bring some of those funds to Prince George's County?
My guess is yes. We can. I think part of what the authority has an opportunity for is to form the framework for such collaboration. I think we've talked about it during our meetings over the past year about these opportunities, and one of the questions we kept coming up was, what will be the framework for the collaboration? And I think this authority provides that sort of framework. And certainly, as I said in my initial question, one of the questions is going to be how do you get the money to support such a thing?
Sure.
And so that has to be a part of the focus of the authority is having funds to support the initiatives you want to bring about.
So this
is a now situation.
Yeah, I was going to say,
This already situation is tomorrow, soon tomorrow. I'd love for it to be now, but we've got to be, but this sounds like it's a now opportunity for us to get some funds.
Right, so the letters of intent have already been submitted. It was submitted in November, but they were volunteer. And so the real blessing here is that I think just yesterday, within the last 24 hours, they moved the state back to the beginning of February. And so this is a right now call, like $840 million, 35 grant, it's a cooperative grant. It has to be led by a health system, right? I'm not sure of the FQHC just because of, the funding that you all, but I'm sure there could be some collaboration. And so it's identified, and 20% of those doctors have to come from medically underserved communities, right? And it's a must, it's a must. And I've been steeped in this stuff this last week, and the dollars are out there. This would be an incredible opportunity for us not to go after. It's right now. In the proposal process, the brain trusts are coming together right now to identify what doctors, what primary care, and how we could, bring these dollars. And you can tell them how you want to address it.
We certainly welcome the discussion, ready to have that discussion. Anything that has to do with bringing those types of collaborations to the hospital system. So Dimensions stands ready to talk to whomever that we can talk to collaborate in that effort.
Sure. So, absolutely. Okay.
So I think that's great to do that. And then
I'd love to have that conversation. I mean, we need to bring, that money is here and the time is
now. And for the future, then the authority would be that entity.
Yeah, that would be. I mean, I think the prime on the contract. I can't be the prime because I don't have a health system. Obviously, I want to be a part of it. But the prime has to be a healthcare system that can deliver. And they're trying to reach 150,000 clinicians. Now that's over the whole thousand, and it's a 4-year contract.
If I just said, the DC Primary Care Association is in the process of building a group.
You said DCPCA?
DC Primary Care.
Yes,
to build a group, and they're looking at using CRISP and making this more regional. So there may be an opportunity for collaboration
right.
there.
I didn't want to bring in DCP, but absolutely. I know they're very well. I've been talking with Jackie about that. And it could be a regional. I mean, I think this would be excellent because we know the borders and zip codes are, right
but
here.
But they're also using CRISP. It is regional because CRISP is a
already
Maryland
there.
entity. It's already here.
Yeah.
All of our hospitals are connected to CRISP.
Yeah.
Not all of the DC hospitals are.
Yeah.
So it is regional.
We need to talk to Jack.
Yeah.
So Jackie is on board. I've been talking to Jackie. Donna Raymond is her point of contact. I'd love to. The opportunity is right now.
It's great. I did have two questions, and I want to really thank everybody and echo, this is really fantastic, and says all the things that we want to hear in terms of a countywide approach. the first question I had is that the healthcare improvement zones, are those fixed zip codes, or are they, is the project that, as needs emerge in, new, sort of emerging communities with high healthcare needs, is it set in stone now, or is the idea that there's a sort of an ongoing assessment project? And then the other question is, do you have a sense of dollars of how much it would take to invest? There's a lot of discussion of dollars here, dollars there, investment here. What's a price tag or a menu? And then, in particular, this Prince George's CARES initiative, is there a sense of where those dollars could come from? And if it's in a 1 to 3 years, how close are we? Or how far away is it? And do you have recommendations on where those dollars should come from?
You want to take that?
Well, I'll start with the health investment zones are pretty much set by what you see on the map. And when the colors turn from red to salmon to not red and salmon, then they might likely change, but right now they're pretty much set. As far as the dollars for establishing and just moving forward with implementation, our job really was to get the plan done. And so now we are going to be working with everybody to figure out where the funding for the next steps will come from. And that's going to start as soon as we get the report finalized. In fact, we've started already. But we can't tell you today about that. And what was your other question?
How much? How much?
Do we know how much?
Do we need to ask for, like, if we go to Annapolis, do we need to ask for, how much money do that?
How much money? How much money? I mean,
So we could do, so let me just go on
I can't give you a number right now. But in terms of setting up the authority or taking the steps of initially starting a fund for uncompensated care would be a good, first step to help the FQHCs. And that, we'll take it step after step and in stages. But establishing of the authority would give us that comprehensive approach to a system that really works for all kinds of medical practices.
I'm sure to help with dimensions. When you go to your slide number 28, when you say establish the fund for the uninsured, is that going to be lower than that $20 million? Is that going to be higher than that $20 million? I'm hoping it's going to be lower than that $20 million because that was part of the plan to get that $20 million gap or that $20 million subsidy, I guess, gone away.
If I can respond. It's different. The $15, $20 million operating subsidy for Dimensions healthcare system is something that the county has been doing, and we are hopeful that once the regional medical center is up and running, it will no longer be necessary, or at least to be necessary to a reduced extent. This other funding may or may not have to reach that level because it's primarily for FQHCs to take care of uncompensated care, not hospitals. Hospitals will be able to recover to their rates. We hope and pray. We know. Okay, and we know. And a lot of commercial insurance. Right.
Certainly want to echo all the comments that have been made about the good job that you've done on this report. I think it's just absolutely excellent. But you mentioned in there, at least on 2 occasions, I can't find the second one, but talking about expanding opportunities for residency programs and things of that nature. And I just want to make sure that I'm clear and I'm understanding what we're saying, because I believe that the residency programs and the opportunity for them to come to our regional medical center is a key part for the success of the entire program. I just believe that. However, when you mentioned that expanding the opportunities, I certainly hope we're not just suggesting residency programs that are housed in other parts of the state, just merely get to come here and to get to participate in their residency program. I'm looking more of having these programs housed in our regional medical facility, simply because I think that the opportunities that it gives us to live where we work, where we play, it can just be absolutely phenomenal.
Let me interrupt you.
May we continue?
Yes, and you're absolutely right. And it's about having residency slots. That's why the Regional Medical Center being an academic affiliated, and so it would have those residency programs. And those residents, and those residents then would hopefully stay in the county. And what we also heard is that there's competition for training slots. And so training outside of the county, having those people come into the county to be trained, that's what we want to give first priority to county residents to be in those training slots.
Well, but I want to be real.
It's two residency programs in the county at our hospital. And certainly there is a family medicine residency program as well as an internal medicine residency program. And the focus on these programs is trying to get residents from our county to be part of them. We in our family medicine residency program, which is in its first year at this point, 3 of those residents are, 2 of the residents are from 3 of the residents in our program are actually from Maryland, and 1 of them is actually from Alabama State. So our focus as we look at how we choose candidates is putting a priority on our candidates who are from the region itself. Their training is done, almost all of it is done exclusively in Prince George's County, or within the Maryland area. Some is done in DC, depending upon the specialty needs of our trainees. So certainly our emphasis is focusing on giving them an experience that is really focused within the county itself, and hopefully again that will lead to them entertaining practices within the community.
Well, I certainly hope that we're building up to that we're bringing along students in the county who are going to matriculate to the process, and such that when they get into medical school and they get into the residency programs, they want to come back here to Prince George's County. But I think that if they are appropriately incentivized, because the medical students that are walking out today are walking out with $300,000-$400,000 worth of debt. And just like some of the federal programs, when you appropriately incentivize them to go and to deliver healthcare services in the underprivileged communities for a period of time, there's some sort of rebate that comes back to them, or forgiveness for their loans. But I'll just suffice it to say that, and I know our county executive thinks it's very important to have these residency programs located here in Prince George's County, because when that happens, the ancillary development that goes along with that, the houses that are purchased, the retail that is utilized, is just absolutely tremendous. And I don't think that we can overlook that. So I want to make sure that your final report talks about the need to have these residency programs based out of our regional medical facility.
Okay. Now I'm going to turn the meeting back over to Betty Hager-Francis, who is going to welcome our county executive to our meeting. Thank you, Vanessa. And ask Mr. Baker if he has any comments that he'd like to make.
First of all, excuse my attire, but I actually did run up to the office today, so I didn't. That's right.
That's healthy.
That's right. See, I figured it's a health meeting, I'm going to run. One in every group. Actually, from Riverdale Baptist. Nice run in the rain. But let me just say this, and I'm going to turn it back over. I want to thank everyone for all the work that you've done. I said this in the inaugural, and I'm glad that Councilwoman Turner is here. One of the things that we made in the very beginning of this administration, and I've probably said more often if people want to hear it, is that, there's always 3 issues dealing with the county that you hear about: education, public safety, economic development. What we found coming in here, and it really was because of leadership of the chair and when Betty came on, was that if you looked at those first 2 important issues, education and public safety, the driving factors, whether good or bad, had to revolve around health. And so it made us in the administration actually look at health and health disparities and access to quality health and those things in a different light. By doing that, we elevated, and quite honestly, people thought we were strange when we said, education, public safety, health. And then to actually have the administration drive its philosophy around that has been important. I dare say that health has had the impact, and if we had our police chief, fire chief, and public safety folks here, they'd say the same thing. What Prince George's County's health situation is in an honest and robust manner, and then how do we move it forward? So I'm just glad that this work was done. It's interesting, I'll close with this. The conversation, and Madeline knows this, the conversation in Prince George's County is always around one issue in health. That's the hospital. As if that was the beginning and end of our health issues. Not our clinics throughout, not how we have primary care and, and how we connect the holistic approach to health, but it was the hospital. And so we wanted to drive the conversation away from a hospital. And even when we talk about the hospital, it's a regional medical center. That's a spoke, that's the wheel, you put it out to these different. But it never stopped the conversation about how do we do the clinics, how do we provide health care, and then how do we get doctors here in this county want to get here? How do we build economic development around our health facilities so that we've gone from just talking about a hospital to how do we have living in place? It's a health issue. Access to health. Caregivers. Health. So both in terms of the way we pushed it from a policy standpoint and from a personal standpoint, health became very important to me. I love Dr. Cooper. I don't want to be a frequent visitor of Dr. Cooper. I've seen it from a realistic standpoint in ways that probably it's a blessing in disguise because I probably wouldn't understand it, at least in terms from a client, in ways had I not had a personal story and a policy story. So this right here, as I said to the cabinet the other day, and you're helping us, you're actually helping us get to the starting line. You're helping us put the blueprint. The real work starts once we get all this together, and then we see if we can actually make this happen. That's it. I mean, but it's both scary and fascinating and exciting at the same time. Because of all your work that you've done over this long period of time, we actually take it from this paper and put it out here. We have to change things in ways we've never imagined, or people never imagined. I certainly didn't. So I want to thank you for your work. I certainly want to thank you for your leadership and allowing me. You're such great people that I could just actually run up here, just come in and say thank you. Thanks for being there.
Do we have any other questions?
I was just wondering when this group might see the report.
I'll have to turn that over to Vanessa or Betty to answer that question. When to see the report, when the report will be released, the written report.
When it's gone through the internal review. It's going through internal review now.
So there won't be any review by this group prior to the public.
There likely will be after the internal review. Yes.
Okay.
And what's in the report will be an elaboration on these. So this
Right.
presentation was developed from the report, so it would just be more detail and elaboration, but no differences in the actual, the recommendations themselves will.
Well, as you know, I'm always interested in how nursing is presented there,
Yeah.
and I didn't hear
Yeah.
that talked much about today, so I was looking for that in the report.
Okay.
Okay, Okay, if we don't have any other questions, then I'm going to turn it back to Betty, who had talked about that she will end the meeting and talk to you about the rating and steps we're going to make.
Well, I just want to say, I want to echo what both Mr. Baker, Mr. Majette, and Ms. Pam Creeper have said. I thank you all so very much for your commitment to this effort. I have to thank Vanessa and Glendia and Ann King and your team from JSI. You've done a magnificent job. This report is fashioned. It is unique to Prince George's County. We recognize and appreciate it, but it is so because of the advisory and stakeholder committee meetings and the work that you've done. I mean, we had 4 of these kind of big meetings, but then all those work group meetings, and people came and worked in those work group meetings. And we came out with some really good, really solid recommendations that are implementable. I promise you that all it is money. Once we find the money, just show us the money. Where's the dollar sign? Show us the money, and we're going to move it forward, and we're going to actively seek the funding. The money man was sitting right there. Yes, Thomas left. Once he figured what we have had conversations, but we're going to need outside funding as well. The county can't fund all this. So we're going to need outside funding as well. So Jean, thank you for that suggestion, that opportunity. And so we're going to be working with you in the future. We may go into a little silent spot, initially, but we are moving ahead with all of this. And I just thank you all so very, very, very much for your work.
And I'd just like to say I'm happy to volunteer to help, literally out under your direction, however you want me to do, because the deadline is moving. And
what is the deadline?
The deadline is February the 5th. However, we would just need to, it's a lot of, proposal writing, it's a lot.
Right.
So I'm more than happy. It would have to be,
Okay, thank you. All right, we'll talk.
Okay. So, I just want to thank you, really. It has just been incredible to work with you all, and I'm very excited about how this is going to move forward. And want to just, Betty, to echo what Betty said, the time and commitment that you guys have put in, that you come prepared. We did lots of individual interviews with people. They were very open and honest, and it just really helped to bring this all together. So really, really appreciate that from the JSI team, and working with Vanessa and Glendia was really great. It was really nice to have you guys. So with that, I just want to say that there is that community-wide meeting March. It's in March. Has the date been set for sure? We're still finalizing the date in March. March the 7th. And everyone will be aware of that, but please let your community folks to know to come to that, and we'll do this presentation to the community-wide as well. And with that, I guess we are adjourned. Thank you very much, and enjoy the rest of your day.